Next, we have the keynote address by Dr. Anuradha VK. She's the head of the UVA department at Arvind Hospital, Coimbatore, and she's a co-investigator, a principal investigator in multiple studies, and she has various publications in both national and international journals. So she's going to speak. When you hear hoofbeats, think horses, but don't forget the zebra. What do you, ma'am?
Thank you, Dalia, and the organizers of Drishti for asking me to be part of this program. So this is something, which has been hammered into our head, as doctors, that when you hear hoofbeats, think horses, So what is most probable, most likely is, going to be your diagnosis. But unfortunately, diseases don't read textbooks. And uveitis is one of those specialities, where you can throw a curveball at you, every now and then. So I'm going to share 7 cases, which I've seen during my career and, I'll tell you what I've learned from it. So my first patient was a 23-year-old seminary student, already diagnosed with Behçet's and on methotrexate. And he actually moved from Arvind Madurai to Arvind Coimbatore. Because at that time, his left eye had already lost some vision due to macular scarring. Right eye was his seeing eye with 6/6 vision. Because he was not adequately controlled on methotrexate, this is in 2013, I put him on cyclophosphamide. And for a while, he was doing well. And then, because of concern for a respiratory infection, I stopped the cyclophosphamide. And after talking to the pulmonologist, just bumped up the omnocortical to around 25 milligram 30. And then one day he comes with a sudden drop in vision in the right eye. It went from 6/6 to 5/60 overnight. Okay. Now, although it's not very obvious, there's a significant vitritis. Inferiorly, there were a lot of pre-retinal exudates. You can see the hemorrhages with the retinitis or retinal infiltrates. Now, because this patient was already immunosuppressed, had a respiratory infection, I was very concerned about an opportunistic infection in this case. So we took him for a vitreous biopsy, sent the sample for PCR and smear and culture, both for bacteria, fungus, virus, and toxo. All of them came out to be negative. So we put him on IV methylprednisolone, not for the usual 3 days, but for 5 days. And then I referred him to rheumatologist for biologicals. Initially put on infliximab and then on adalimumab. He actually did very well. He responded to the treatment. And he was kept on triple immunosuppression with azathioprine, cyclosporin, and low-dose steroid for a long time, but he has come off the steroid now. And this is him about 10 years later. You can see he's maintaining 6/9 vision in the right eye. Left eye is around 6/24. So Behçet's is a very unique disease in that, and it's not uncommon in our part of the world, particularly in Kerala. It's a non-infectious uveitis which is capable of mimicking a spectrum of infectious uveitis. So it can present with hypopyon and pre-retinal exudates mimicking an end-off. The retinal infiltrates in Behçet's can be mistaken for toxoplasma. And I've even seen a case, which presented with what looked like a subretinal abscess. So you need to keep that in mind. Our second patient is 34-year-old lady who referred as left eye intermediate uveitis with pain, redness, and decrease in vision. There was 2+ cells and DM folds in the cornea. And you can see in the fundus photo there is significant vitritis, vitreous opacity. There was no focal lesions visible in the fundus. There was no vasculitis, retinitis, or choroiditis. My colleague, who was smart enough to look at the anterior vitreous face, however, picked up this. You can see that it's a very active motile worm in the anterior vitreous face. So the patient was taken up for vitrectomy, during which process the worm was eaten up and then treated with a combination of albendazole because we couldn't identify the worm. It treated with a combination of albendazole and steroids and did very well. This is another case, and this kind of a picture might be more familiar to you, but it is still a relatively underdiagnosed condition. It is DUSN. As a 40-year-old male presenting with decreased vision, pain and redness in the left eye, referred as multifocal choroiditis. So that's what usually happens with Duchenne, it's referred as multifocal choroiditis. And you have this multiple lesions, which are subretinal. And what is characteristic about it is a clustering. So, and the lesions are in different stage of healing. So the lesions here, they have healed, and these yellow lesions here, they are active. You can also see the tracks here. Okay, you don't see tracks in all cases, but when you see this lesions, very small lesions in varied stages of healing and clustering, you should think about Duchenne. And if you have an OCT, do run it through the active lesion. These lesions are not in the choroid, they are in the outer retina. So in this case, there is a live worm there subretinally. I hope you can see it. Yeah. So the patient was treated with laser to the worm and combination of albendazole and steroid and recovered 6/6 vision. Now, parasitic infections causing inflammation, it's a difficult to pick up, for multiple reasons. One is that other than Duchenne, they may not present with a specific pattern, so it might look like intermediate uveitis or anterior uveitis. And the worm, is very difficult to locate. You may not always find the worm. But it's important that you do gonio, important that you check the anterior vitreous face and do a thorough examination of the fundus. I find that, looking, where the active lesions are, you have better chances of picking it up. Yeah. A fourth patient is a 48-year-old female on HART since 2007. And she's also undergone surgery for Regardie in the right eye in May 2007. So she was coming in for a routine follow-up. Right fundus is not visible because of a very thick PCO. And the doctor who examined her in retina, happened to note the choroidal folds and a subretinal pocket of fluid around the disc. So I was referred to UVA department, and the OCT confirms the presence of SRF, choroidal thickening, and the RP undulation. And a B scan of both eyes shows RCS thickening in both eyes with exudative VADI in the right eye. FFA shows the typical pinpoint leaks with late pooling here. So a clinical diagnosis was, all the baselines were negative, Manto, TPHA, everything else was negative. The CT chest was, the chest X-ray was normal. So we came to the conclusion of sympathetic ophthalmia, secondary to VR surgery in the right eye. So after clearance from the ART physician, who assessed a CD4 count, did a viral load which was undetectable, she was cleared for high-dose oral steroids with methotrexate. And this is the response to the treatment. You can see the reduction in the RCS thickening and the resolution of exudative VADI. So when you think of uveitis in HIV patients, you think opportunistic infections or a masquerade, which is, is a correct thing to do. But, do not think that, these patients cannot develop an autoimmune disease. It is known to happen. There are other reports of VKH in HIV patients. The other thing which you should not do is, just because it's a HIV patient, you should not think that you can treat it locally or ignore the protocol. Something like sympathetic ophthalmia is indication for primary immunosuppression, and you have to get in touch with the treating physician, have a good talk with the patient, and follow the protocols. Case 5 is a 30-year-old male patient known to be an open case of pulmonary TB, sputum positive on ATT for 2 months. Now complaining of pain, redness, and decreased vision in the left eye. And by the time he came to us, the left eye had neovascular glaucoma with IOP of 44. The vision was down to PR inaccurate. And the media was very hazy, and through the haze, we could see a yellowish mass at the back of the eye, confirmed on B scan. You can see here dome-shaped mass with variable internal reflectivity and exudative retinal detachment. So this was thought to be more fitting with a granuloma. He was HIV negative, so we put two and two together, you have a yellowish mass, happening in a patient who was on treatment for pulmonary TB. So after clearance, we started him on oral steroids under cover of ATT, of course. The first couple of visits, he was okay. 2 months after initiating steroids, and when we started tapering it, he comes in with extra scleral extension of the choroidal mass, and you can see that here in the ultrasound as well. Now we were very worried. We knew he was compliant to treatment. We knew drug resistance was unlikely because the pulmonary lesions had resolved and the sputum had turned negative. So then we thought, we have landed in hot water, missing a tumor, either a primary or secondary tumor. So we went ahead with a systemic evaluation. There was no sign of metastasis anywhere, but the CT of the eye and the brain confirmed the presence of the mass lesion extending minimally into medial rectus, optic disc, and proximal optic nerve. And the diagnosis was likely to be malignancy. So we went ahead with enucleation of the left eye and sent it for histopathology. I can tell you how much of relief I felt, no signs of malignancy. And this one turned out to be an intraocular granuloma here, breaking through into sclera, into the orbit. And although they could not see the organism in the histopathology, the tissue PCR turned out to be positive for TB and negative for fungus. Now, ocular TB can have paradoxical worsening, and this is a case of extreme paradoxical worsening in this case. So, Dr. Dalia was talking about primary vitreoretinal lymphoma, which is the most common malignancy, which can mimic a uveitis. And then somebody who's practicing, uveitis, we're always worried about, missing a malignancy. And I have to say that over the last 10 years, I feel that awareness has spread among people, and more people are, recognizing PVRL, even when it presents like uveitis, and that's a very, very welcome change. So this is our sixth case, a 41-year-old lady who was 36 weeks pregnant at the time of presentation, coming with decreased vision in the right eye for 4 weeks. She didn't have pain, but there was a temporal scleral congestion. So when you looked into her fundus, what was striking is this large clump of subretinal exudates. And you can see that here along with the exudative vadi. And then there was this smaller orange yellowish mass in the supratemporal quadrant, which on B scan showed moderate reflectivity and minimal amount of subtenon fluid. So with subretinal exudation and subtenon fluid, scleral congestion, we were thinking more in terms of an infection or an inflammation. So she was taken up for right vitreous biopsy with and given intravitreal antibiotics. The sample was sent out for PCR and end of panel testing for bacteria, fungus, and tuberculosis. All came out to be negative. After that, the patient chose to follow up locally, but we were in touch with the local ophthalmologist. And they told us that, she is not responding. And I think the manto was borderline positive. So we decided to start her on ATT and oral steroids. Even with that, she kept worsening. Finally, after she delivered, she underwent a full workup. And it turned out to be a moderately differentiated adenocarcinoma of breast, which had metastasized to all parts of the body, including the eye. So we don't expect, metastasis to present with such florid inflammation, and certainly, I've seen cases where there is vitreous cells, AC cells, but I've never seen this kind of a subretinal exudate in a metastasis before or since. So some of the lessons I've learned from this is that, we should have actually checked for cervical lymphadenopathy. That's something we missed. And secondly, we did not do a chest imaging, because she was pregnant. But actually, if indicated, it should not prevent you from imaging the chest. It is perfectly fine to do it. In chest X-ray, CT scan, it is perfectly fine. And last patient is a 65-year-old male coming with defective vision both eyes for 20 days. And when you look, both eyes have this very ill-defined yellowish subretinal lesions here, multiple lesions, which on OCT, in addition to the subretinal fluid, what is very striking is this thickened hyperreflective retinal pigment epithelium, which is, kind of absent in some areas here and here. And there is a layer of subretinal hyperreflective material as well. So this picture, didn't fit into anything which I knew at that time. So we're just thinking atypical CSR, atypical VKH, syphilis. Okay. So the autofluorescence, can I take? The autofluorescence showed a confluent hyperautofluorescence corresponding to the hyperreflective RPE, and the discrete hypofluorescence corresponds to the gaps in the RPE, and the FFA is a mirror image of the autofluorescence. His baseline blood tests were all normal. Even ESR, for somebody of his age would be considered normal. So finally, we thought, after doing literature research, we thought idiopathic polymorphous vitelliform dystrophy. And we called him back after 10 days, after the initial consultation, and the SRF started resolving spontaneously, much to our joy, and that was the same in both eyes. And then we asked him to come back after 2 weeks, and the SRF is back. So same thing happening in the left eye, went back and went into more details into history. He said he has loss of weight and altered bowel habits. He was referred to oncologists who diagnosed carcinoma colon with widespread metastasis. So this is acute exudative paraneoplastic polymorphous vitelliform maculopathy. So my take-home points are, you should never try to slot a square peg into a round hole. By that, what I mean is, when you look at an eye and, you're thinking, it's neither this nor that, don't come to a presumptive diagnosis and start presumptive treatment. Go back to the history, reinvestigate if necessary, or get a second opinion. Second is, whenever I have tried to override my gut instinct with my brilliant logical thinking, I've always landed in trouble. So if your gut instinct is telling you, there's something wrong, this is not working, listen to it. And third is, it's very important for you to be honest with the patient. It's not like, you're the treating doctor, so therefore, you always have to give them a definitive diagnosis. You can tell them that, I've looked at you and these are the possibilities I see, and this is my plan A, and this is my plan B, and this is my plan C. If the patient sticks with you, well and fine, otherwise, it's very unlikely that they will come back at you, later saying, you screwed up my eyes. And lastly, learn from mistakes, either from yours or even better, from others. Thank you so much for your patient listening.
Thank you, ma'am, for those very useful practical tips. What you said in the giving possibilities to the patient is, I think that's the most important thing, because then you earn the patient's trust also. Because they also know that we cannot make a definite diagnosis in such a difficult case, and then they have a good follow up. They come for a closer follow up. They're ready for that. So that's a very useful tip. Just one question: in Dusan, what is the dose of albendazole which you gave?
400 milligrams.
How many days? They saying for 30 days now?
I do.
Yeah, it's for 30 days.
4 weeks,
Yeah, so that's, thank you, ma'am. So I think we have run short of time. Any queries from the audience?